very good morning to all of you. Thank you for inviting me here. And I'm going to discuss a challenging case. This is my clinic, and for this challenging case, you will have to focus like my dear friend. So, this is a patient who had presented to us with breathlessness on exertion, and he had his WBC count, which was, where is the cursor? Yeah. So the TLC was 3000, neutrophil was 67%, the CRP was 155, the ESR was 52, and this was the chest X-ray. As we can see here, there was a right-sided pleural effusion, and this patient was having fever on meropenem and amikacin, and that's when the reference was sent from RGCI, Rajiv Gandhi Cancer Institute, in 2021 for fever and breathlessness. So as ID physicians, we reviewed the history. This was a 31-year-old boy from Delhi NCR. He was having B-cell ALL on maintenance therapy with Dasatinib, and he had a relapse. He received chemotherapy. Post first CT Mini Hyper-CVAD therapy, he was put on Ponatinib 45 milligrams once daily. Then subsequently, he was admitted with febrile neutropenia, and he had a TLC count of close to 2000, and he was initiated on meropenem as well as amikacin, and despite this, there was persistent fever. That's when an X-ray was done, which showed that there was a right moderate pleural effusion, which was tapped, and it showed it was exudative. He was initiated on caspofungin for 14 days because of the persistent fever, and which was stopped after 14 days of therapy. Now, after stopping the therapy of caspofungin, he was readmitted on meropenem as well as, he was readmitted and was started on meropenem as well as amikacin, which was continued for 2-3 days. On persistent fever again, caspofungin was started, and this time he was again having dry cough. If you look at the CRP, it had jumped from 2.4 to 155, and that's when he was sent to us. Now at this point, with fever on meropenem, amikacin, and this history and a chest X-ray which is showing a right-sided pleural effusion, they had done a CT scan, and the CT scan was suggestive of again few tiny nodular opacities in the left lung. Reviewing the history of the pleural effusion culture, it was Candida dubliensis, which was isolated, and this was fluconazole susceptible. With this CT scan, we did the serum galactomannan, which has been emphasized by Dr. George Verghese over here, which was 4. Now, and also MTB was, expert MTB was done, which was negative. Now with this, which antifungal therapy will be the preferred therapy? Should we start the patient on liposomal ampho-B, echinocandins, voriconazole, posaconazole, or a combination of liposomal ampho-B with voriconazole? Panelist.
Can I have some comments from the audience, please, first?
So the renal status is fine. His creatinine is fine, absolutely.
Can you use the mic, please?
Yeah, he is right now on Ponatinib, 45 milligrams once daily. And he also has a pleural effusion, which earlier had grown Candida dubliensis. And he received caspofungin for 14 days, stopped therapy, then again started having fever and breathlessness. The repeat CT scan, which was done, shows effusion along with nodular opacities in the opposite lobe. And a galactomannan is also positive now, which is 4. So what do you think it is?
Yes, madam. The thing is that infection focus is there, okay. But one of the thing is Dasatinib can also cause pleural effusion. In Harrison 28th edition, it's clearly given A, B, C, D, and amiodarone, bromocriptine, procarbazine, Dasatinib, and nitrofurantoin. These are the drugs which can cause pleural effusion also. Since it is shifted, now regarding this infection, I want to start on the...
He's on Ponatinib.
So what is your choice?
I will go with 5th choice, sir.
Combination therapy
Yes,
of liposomal ampho-B with voriconazole?
That is just my opinion.
Okay.
because the patient, the pipes are okay. Renal
Okay, I will
status
take
is
some comments from the experts.
So first, yeah. No, please, you.
No, to say candidal pneumonia is a very unusual thing. To find a candidal pneumonia, because anytime candida grows in the sputum or in the bowel, we say it's probably a colonizer. So in the pleural fluid, you have found candida. So was the collection correct? Was it a true, candidal pleural effusion is something that I would think first. So in fact, in this patient, just relying on the old culture and starting treatment is not something that I would do. I would probably ask for a bronchoscopy and BAL, get a proper sample. This could be something other than candida also, some other fungal infection.
No, but the galactoman is already positive in this. No, that's okay, but at least you have got a simultaneous when galactoman positive and CT scan also shows the multiple nodule in that. So you are expecting two infections. One candida is sure, but other infection in the lung, which as you said, it's not candida pneumonia, most likely some mold infection. So now this mold, what she is trying to say, that mold is not detected, only you have got a indirect marker, serum galactomannan, which is there positive. So whether you like to give what drug, that is the question in this.
So I would just a second. Yeah.
Yes, sir.
What drug, this question can come after what is your diagnosis.
Correct.
So here, let's pause here. Are there any better films? Because this film is quite a disaster. There are nodules. No, not a joke. On the left side, you are still seeing nodules. They're tiny, agreed,
True.
but they are there. Okay, so again, you cannot explain anything on this basis.
So we have the report as well.
One moment, I don't look at the report. I am looking at that film. So what are you seeing there? There is some other parenchymal lesion there,
So,
which is cavitating.
yeah, absolutely.
So how
Yeah.
is all this explained on the Dublinensis? It certainly cannot be explained.
On what
on
can we explain,
Candida
sir?
Dublinensis, which
So
has
there
been
are
found.
exactly. So it cannot be only explained on Candida dubliensis. We have perhaps two things happening
Yeah.
here.
So before that, you want to start treatment, or you want to do something else to get at the mold?
So this was a patient who was coming to us in the OPD. Now look at the treatment part as well. He earlier had received meropenem amikacin. He was not responding, and when the caspofungin was initiated, that's when there was a response. Now it is the caspofungin was initiated on the basis of the Candida dubliensis, which was detected in the pleural effusion. It was a Candida empyema. He had a clinical response. But when the caspofungin was stopped, because this was a short duration and probably for an empyema a longer duration was needed, he had a relapse of the infection. And as this is a BALL with functional neutropenia, he subsequently also is prone for invasive aspergillosis. So there is a Candida pneumonia along with probable invasive aspergillosis in this patient, which is based on the host factors, the radiology, which is suggestive of upper lobe infiltrates, as we can see it in the CT scan, and a biomarker galactomannan positive. So this is a Candida pneumonia, empyema, not pneumonia, Candida empyema with a probable invasive aspergillosis. Of course, we can do other invasive investigations, but that was also offered, but he was he was not ready for an invasive procedure. So when we have arrived at this probable diagnosis of two mixed infections in a susceptible host, then which antifungal can we start? So here, the Candida dubliensis was fluconazole susceptible.
Ma'am, can you tell us about the sample? How was it a drain or was it a direct aspiration?
No, it was done in the blood culture bottles as well.
No, but how was the pleural fluid obtained?
It was a IR guided aspiration which was done. The exact details I don't remember now as of now, but it was a IR guided aspiration which was also sent in the blood culture bottles.
So we know about the infection. Just a second. We know about the infection 1. Let us concentrate on that first. So can I have the next slide?
Yeah.
Yeah.
So,
just a second. Sir, I was just,
I was just thinking, can it be CPA? Chronic pulmonary aspergillosis, cavity colonizing that aspect? Or it is an invasive pulmonary aspergillosis?
So the previous scans did not show any nodular infiltrates there. And this is a patient who is neutropenic.
Can you show the CT scan again? The cavity, and there is a
the previous one.
mass in it inside this. So don't you think it's a cavity which is being colonized with some mold?
So if but if there is a patient who is having neutropenia and we see...
the question is not the neutropenia means invasive aspergillosis. What is the evidence here?
Yeah, but there is a nodular infiltrate which is cavitating. So dense consolidation cavity is also suggestive of probable invasive aspergillosis as per the radiology. And then we have the galactomannan which is positive as well.
The galactomannan can be positive as well in chronic pulmonary aspergillosis as well. So I'm just saying that is it a mixture situation that CPA can also lead to IPA?
Probably yes, that is also possible. But here the previous scans were not showing any nodules.
Okay, let's proceed.
Okay, so with Candida empyema and a probable IPA, what do you think we should start in this patient? So here...
I'll answer your question.
Yeah.
You want a drug therapy to be started. Awaiting probable or definitive diagnosis. Now in this case, I am not very happy in giving azoles to the patient because of the drug interaction with various other things that the patient might be having. So azoles are out. Echinocandins you've already given for 14 days. It hasn't given you brilliant results. So even echinocandin is out. So that leaves only liposomal amphotericin B. So that's my answer.
Okay. Definitely, I think in view point are valid, but in a patient who comes to the OPD, liposomal amphotericin B is going to be like expensive and IV therapy, and the patient was, again, it is probable IPA. Now, we also know that in our country, in the ICU, it is Aspergillus flavus, which is more common as compared to the fumigators, and this is based on this FISF study, which we know. And the problem is with Aspergillus flavus is that there are higher MICs, so the drug of choice would be voriconazole here. Of course, liposomal ampho-B is definitely a consideration. So in this patient, what we started was monotherapy with voriconazole, which would cover both Candida dubliensis empyema as well as the invasive aspergillosis. Echinocandins alone should not be given because they are static against invasive aspergillosis. Now this patient was on voriconazole as well as on Ponatinib. Now 10 days later, during this period the fever also resolves, he does well, but 10 days later he comes again with breathlessness, and this time there is no fever. And if we look at the scans here, there is an increase in the right-sided pleural effusion. Now what is likely in this patient? Breakthrough invasive fungal infection on voriconazole, superadded bacterial infection, both or none of the above?
We have treated with voriconazole only.
Yes, I have treated, we've started only voriconazole in this patient.
Wrong diagnosis first. Probably we never got a diagnosis. We are just shooting darts in the dark. So I would have actually pushed this patient for a bronchoscopy in the first place itself, and rather continue treating him empirically.
Okay.
So it could be anything. It could be fungus, it could be bacteria, it could be, who knows, right now he's got a viral infection because he went back to the community.
Okay, any other comments from the, I'm being short. This is like the first slide which is getting manifested. Okay. Yes, sir, please.
First of all, caspofungin penetration into the pleura is not good. Okay, it is among the echinocandins, it's micafungin. So I am not ready to believe that that has worked or not worked and all that. I can make no comments on that. After that, you have started voriconazole, but within a short time, he has got this. It is quite possible that that lesion has ruptured into the pleura right now. And so, again, you will have to do a tapping to see what is happening there. And a proper CT scan with a good image, which anyone can, even clinicians can look at, and so on. So,
Sure, the radiology is very important. Okay, now.
it's very, very important.
Yes.
It's important to consider which drug you are using, what is the site of infection, does it penetrate well, were you using 70 milligrams daily or 50
So we'll
milligrams
just take
daily?
one more
And
because
so
the
on.
time is up. We'll have to go to the next case.
I am a consultant
Yeah.
pulmonologist. I'm sorry to say this. This case was in 2021, depth of COVID scenario. This case was in 2021, June 2021 is a second wave of COVID scenario. Definitely this type of, we would have gone for bronchoscopy, proper pleural drainage, take a proper sample and proceed for further management. And this, you can't wait for giving voriconazole and then proceed further, wait for 10 more days. And being a hematological patient, I would have proceeded for bronchoscopy and pleural drainage before thinking about anything else.
Yeah. Thank you.
Okay.
We'll
Point,
come for-
very valid point.
Yeah.
So we did consider that. However, when we look at clinically, every point is very important.
Yeah,
Now
thank you,
this-
Dr. Neha. Your point well taken. We'll have just running out the time.
So I will just
please
do it
conclude.
very quickly now. This patient did not say, there was no fever. Fever which was happening had resolved by now completely, and he was having breathlessness. So we did consider for the, again, IR guided TAP. Again, clinically, he was not toxic. That was also very important. So when we have a patient who is having right-sided pleural effusion, which is increasing, why is it happening? Is it infection or is it not infection? Whether it is the Candida dubliensis empyema which is failing, or it's another complication which is happening, or a superadded IF5 breakthrough like a mucormycosis, or is it a non-infective etiology which is because of the drug? So we did look at that, and as he had mentioned, Dasatinib results in pleural effusion. Ponatinib is also associated with pleural effusion in 3 to 19% of the cases. So here, the next step was to look at the drug interactions. So this patient was Ponatinib and on voriconazole, although the dosage of Ponatinib was reduced from 45 to 30, but still there is significant interactions between Vori and Ponatinib, and Vori increases the levels of Ponatinib, which probably was resulting in the side effect of pleural effusion. Now the other option is posaconazole and Ponatinib. They are also associated with significant interactions. Both of them increase each other levels. Coming to which other choice can be used, isavuconazole is associated with no interactions, which is predominantly, that's why we shifted this patient to isavuconazole, and a few days later, the pleural effusion resolved. So of course, invasive investigations are very, very important, but at the same time, clinical history, clinical symptoms are also very, very significant. This, luckily, we had published it in the FISF as well, and requesting you to kindly share your interesting cases to Dr. Tanu Singhal ma'am for the FISF newsletter. It is important for us to judiciously use the antifungal agents, and like it has been taught by our pioneers, including Dr. Ajike sir. Thank you so much.
Thank you. Thank you, Dr. Neha.